you get paged by the nurse, hey, this patient is hypertensive, what do you do? Okay. So now, like a similar exact scenario, but you get paged that the patient is hypotensive. Okay. So now it's kind of a little bit of a different situation. You're getting paged that the patient is hypotensive. And regardless what time you get paged. So some of you might be a night float where you get paged that, hey, patient's hypotensive is like 2 a.m. Some of you might be during the day. Okay. So regardless, when you get paged, you got essentially you have a page that says, patient X is hypotensive. Right? Usually the nurse will tell you a little bit more details. Hey, his blood pressure is 80/40 or something like that. Okay. So let's say the nurse is telling you, the blood pressure is 80/40. Okay. Just like when you get paged about hypertension, the first thing you want to do is to go, assess the patient. Very important for you to know, don't take hypotension lightly. Okay. So this is like high alert thing. The reason why this is high alert is because any change in the status of a patient is considered a change of his clinical or her clinical status, and that may indicate that the patient has sepsis. Okay, so I'll just stress this out, is that any change in clinical status equals sepsis until proven otherwise. Okay, so keep kind of this fact in your brain as you see patients. When you're seeing a patient and there's something happening, all of a sudden change in status, keep in your mind that there might be sepsis going on. Okay. And I'll explain to you why when we go down into the algorithm of this dealing with hypotension. So let's say you get paged, patient is hypotensive, 80/40. Okay, so you're gonna see the patient. Okay, and the first thing, oh, somebody's saying you can't see what I'm sharing. Give me 1 second. Can everybody see my screen?
Yeah, I can't see it.
You can't?
No, I can't see it.
Okay. I think Abud, you might have a problem. You want to go out and come back in? It sounds like everybody else can see it. All right, cool. So the first thing you want to do when that happens is go and examine the patient. So you're gonna see the patient, and then you're gonna recheck the blood pressure. Okay, so you can recheck it. Let's say you rechecked it and it's normal, then you're good, right? Then nothing really to do. It was a transient, something is wrong, so whatever. Okay, so let's say you recheck it, and again it's like 85/40. What do you think is happening? What do you want to do next, if I may ask you? Do you know what can you do?
Recheck the rest of the vitals, see his heart rate, his
so
temperature.
Right. So first thing, check the vitals. And one other thing you might want to do is, like, when you say check the vitals, so how things work here usually is that there's a nursing aide who comes to the patient room, and she checks vitals every 4 hours on the floor. In the ICU, it's a little different. People might be on monitors, but there's literally a machine that is used, the same machine, kind of multiple machines, but the same one that's used across the floor. So the machine might not be at the patient's bedside, so you might have to go and look for it. So it would be nice to know where these things are. So you go, you bring the machine has the vitals. Essentially, you can check the blood pressure, you can check the heart rate, you can check the pulse ox, and you might want to take a temperature if you want to be complete. Okay, so these are the things you want to check right after this. But what else can you do? We said, same way you deal with hypertension. What else do you want to do when the blood pressure is this low? So you rechecked it, but you want to make sure, صح? So what can you do? remember, the cuff that you're using might not be, a good size. So what I suggest is use a different cuff, right? Use a different cuff. So sometimes, the cuff might be too big. Okay, so you might want to use, a different cuff and see if the cuff is too big. Okay, and finally, you want to use a different arm as well. Although, as with hypertension, you want to be careful when you use a different arm. Okay, because be careful if there is an actual difference, an actual difference in pressures, then differential blood pressure means maybe there's a dissection or something big going on. Okay. So if you do all these and then, you're like, you're normal, you're good, there's nothing to do, then, you might be good. Okay. So if things are normal here, then you might be okay. And let's say you do all these, and then I'm just going to walk you through this scenario, and the blood pressure is still 80/40. Now, what are you facing? What is the situation? So if you think about it, now the patient is hypotensive, right? So acute, the patient has hypotension, which means, what are you worried about when somebody is hypotensive? What is the other word we kind of throw around when somebody is hypotensive?
Shock.
Shock, exactly. So the question in your mind should be, is there shock? Is the patient in shock, right? What defines shock? How, like, if I'm hypotensive, am I in shock? Not necessarily. So what makes me in shock versus not shock?
Tissue hypoperfusion.
Tissue hypoperfusion, exactly. So the question is there tissue hypoperfusion? This is like a physiologic question. You can wonder, in the universe, is the patient having tissue hypoperfusion? But there's an easy blood test, right? What blood test would you kind of think about when somebody is having tissue hypoperfusion?
ABGs.
Not necessarily ABG. So what happens when you are hypoperfusing your tissue, any tissue, the aerobic respiration stops. What takes a hold?
Oh, lactic acid.
Yeah. Exactly. So
Hmm.
your pyruvate goes up, and then you end up going into the lactic acid cycle instead of going into the Krebs cycle, which needs O2. So your lactic acid will go up. So remember, hypoperfusion equals increased lactates. Okay. So that's kind of the hallmark of having a hypoperfusion, is that your lactate is up. Okay. Now, at this point, you're still undetermined whether the patient has hypoperfusion or not. But for all intents and purposes, you're going to assume that the patient's probably having hypoperfusion because they're hypotensive and you don't have an explanation. There's one more thing I would add is, before you make it a big deal, okay, always ask, is the patient sleeping? Okay, because a lot of people, when they're asleep, their autonomic nervous system goes down a little bit, and then, they might be hypotensive. Okay, Hala, let me ask you a question. If they're sleeping and their blood pressure is 80/40, okay, would you just, wake them up and then recheck, and then you're good? What do you think? In a real world, in an imaginary scenario, this might be a good idea, but in a real world scenario, I wouldn't advocate for this. What I would say is that once you see this hypotension, especially that you measured it multiple times, consider it serious. Just take it seriously and deal with it as if the patient is probably in shock. Okay. So what I would say is, at this point, okay, at this point of the algorithm, okay, it's very important that you, as the intern, you're the bottom of the ladder, you still don't know a lot of things, is you have to notify your senior. Okay, because a lot of times, you can deal with it by yourself, but at this point, you want to notify somebody that the patient is hypotensive, it's legit hypotension, and we need to take it seriously. So we need to do the next steps of management. Okay, so there's kind of two separate ways now you go about doing this. Is first you have to determine the reason. Is why is the patient hypotensive, and then the other part of it is treat the hypotension, right? Sometimes they're very they interact with each other, okay? But this is kind of the way, you think about it, is that, okay, I want to try to figure out why they're hypotensive. At the same time, I want to, treat the hypotension, okay? So to be honest, once a patient is in shock and they're hypotensive, what do you think that requires? Like once somebody is in shock, can they stay on the floor? What do you think?
No, they need extensive monitoring.
Exactly. So you need to do some monitoring. So at this point, once you determined that the patient is hypotensive, okay, one of the first things you want to do is you want to continuously check their blood pressure, okay? So at this point, you want to do Q 5 minutes or Q 10 minutes blood pressure monitoring with the cuff. Just continuously monitor their blood pressure. So at this point, it's a scene. The lights are on, the patient is not sleeping anymore, the nurse is in the room, maybe your senior is here. It's like something is happening. Okay. Some people sometimes call a rapid response, you will hear about this word. It's called a rapid response. And this just means that you're calling in more people to help you out, figure out what's wrong with the patient. At the same time, you're also calling help from the ICU. Some hospitals might have an ICU consult specifically for this, so you can place an ICU consult. But some institutes, some hospitals will have a rapid response team, and one of the rapid response team members is probably the ICU resident or the ICU intern or somebody from the ICU, okay? Which they come and then they know the patient because they might end up in the ICU, okay? So as part of determining the reason, okay, the things that you're gonna order, what are you gonna order for these patients to determine the reason of hypotension? You want to do some blood work, right? So what can you do in terms of blood work? So usually there is an order set for these things, but you should know it even if there is not, okay? So usually what you want to do is you want to get a CBC, okay? You want to get either a CMP or a BMP, okay? Depending on which institute you have. You can get a PT and a PTT because this is remember, this is a change of status, okay? And then somebody mentioned it, an ABG, right? You want to get an ABG to see if they became acidotic at this point. Is the pH going down and their bicarb is low, and now they're having some sort of lactic acidosis, okay? And these few tests will help you determine that. But very important for you to remember is the following labs that need to be ordered, or the following things that need to happen, okay? First, you want to order a lactate, okay? A lactic level, all right? Another kind of, tip, a lot of people will try to order lactate, okay? And what they end up ordering is lactate dehydrogenase, LDH, instead of lactate. Because when you write lactate in the computer, sometimes the first thing that pops up may be LDH, lactate dehydrogenase. And then you end up, you don't want LDH, you want the lactate level. So make sure that that's important, okay? Another tidbit about lactate. So if I draw my blood right now and I put it outside for 10 minutes, what do you think is going to happen? Lactate will increase because a lot of these white blood cells that are working, they're going to produce some lactate. So lactate will go up the more you leave the blood outside. Furthermore, if you're using a tourniquet on the patient to draw the lactic acid, and the tourniquet is on for 5-10 minutes until you find the vein, the area here beyond the tourniquet might have transient lactic acidosis, and then your value will be wrong, okay? So how do you mitigate that? What do you think we can do to try to mitigate that? Any ideas?
Like order it more than one time, multiple times.
You can, but again, if they order multiple times, they're gonna draw it from the same one, and it's gonna end up in the same batch. So that's not gonna help you. Any other ideas?
No, notify the nurses.
Okay,
give
so
them a
notify the
heads up.
nurse. But what is she gonna do different? How is lactic? How is it gonna be different?
Maybe take the blood from the same sample as the ABGs.
So what are you trying to say? You're trying to say take it arterial, right?
Arterial, yeah.
Yeah, so you can take an arterial lactic. That's definitely better. But again, arterial lactic, if you keep it sitting outside, it's gonna start developing lactate. So how do you slow down the metabolism of blood or of the white cells? What do you think? Or all the cells?
Ice.
Ice. Yes, very nice. So these two things, you draw the lactic and you put it on ice, same way, same way for the ABG as well. ABG is usually drawn arterially, and then you put it in ice, and then you send it to the lab. It's the best way. Okay, a lot of people, a lot of times you're gonna go to the emergency department, they just draw like a venous lactate, and the lactic is always high. Like I wonder sometimes, I'm like, everybody who comes to the ER is in shock. It's insane. But what happens is that the thing is sitting there until the lab processes it. It's in room temperature. So you take it lightly. But here in this situation, when somebody's hypotensive, you want to be really sharp. You want to know exactly what's happening. And again, these things, they go missed. If you don't care for it, if you don't think about it, they might go missing. So keep a conscious eye on it. And it's good to know, early on, even before you start. I think that's why these lectures are important, because a lot of times you don't even know these things. You're going to be like, oh, I don't know how to do it. Okay, so you drew a lactate. Okay, tamam. What next? What else are you going to draw for somebody who's hypotensive? So we drew some labs, we drew the lactate. What's a big thing that might cause hypotension?
Do we need the blood culture?
Blood culture, exactly, perfect. So blood cultures, okay? And usually you want to send blood cultures. Usually they're sending 2 sets or multiple bottles. You don't send 1 bottle, right? You're sending like an aerobic, anaerobic, and a 3rd bottle just to see, usually 4 actually. 2 anaerobic, 2 aerobic. And then you will see which one grows, okay? So blood cultures, okay? You send the blood cultures, right? And which means when you send blood cultures, what are you thinking about? You're thinking about sepsis, right? So what are you going to do with sepsis usually? Because, if you think about it, if somebody reviews the chart, they're saying, okay, the patient was hypotensive. You, the doctor, ordered lactate, perfect. The doctor ordered blood cultures, which means the doctor is thinking of what? Sepsis or septic shock. So how do you treat septic shock? If you're thinking about it, you have to treat it, kind of. So what are you going to give? You're going to give a medication at this point, actually.
We need IV fluids at the beginning.
IV fluids, okay. So I'll give you that. So IV fluids, okay. And then before we talk a little bit about IV fluids, even more important than IV fluids.
Antibiotics.
Boom, antibiotics, yes. Okay. So IV fluids and antibiotics, okay. You see these 4 guys right here? These 4 measures, these are part of the surviving sepsis campaign in the United States, okay? And it's part of the surviving sepsis guidelines, which means if you don't do them, if you don't do these 4, when you're like thinking, if you write the word sepsis in the note, or if somebody mentions the word sepsis and you don't do these 4 things, especially with somebody who's hypotensive, you as the intern or the resident, whoever is taking care of this patient, will get like a notification, because the administration, they will know, and you will be like, hey, you diagnosed this guy with septic shock, you didn't do these 4 things, So these 4 measures are like very, very important. Okay, so it's really important that you do all of them when you're suspecting sepsis. Okay, so once you suspect sepsis, you want to do all of these measures. Another question for you, okay? What antibiotics are you going to give? Narrow spectrum, wide spectrum, which ones? What do you think?
Start with wide spectrum
Wide spectrum.
until the
Okay.
cultures.
So wide. So what's the wide spectrum antibiotic you think about? You want to cover everything on earth. Okay, you don't want to cover fungal, right? Are you going to cover fungal infections? No. Are you going to cover like CMV? No. You want to cover most commonly what? Bacteria, right? Bacterial infections. So, you know, you have gram positives, you have gram negatives, you have anaerobes, right? So what do you think is a broad spectrum antibiotic you might give? This is kind of an unfair question because you guys never practiced here. But just know this, wherever you go, there's a standard broad spectrum antibiotic, okay? The first one is vancomycin, okay? Why do we give vancomycin? What is it gonna cover? It's gram positives.
And MRSA.
And MRSA, exactly. Because you're worried this is a hospital-acquired infection, right? The other antibiotic you wanna give is piperacillin tazobactam, okay? Sometimes they call it Zosyn because tazocin, piperacillin tazobactam. And so what is this gonna cover? Gram negative,
Pseudomonas.
Pseudomonas specifically, and anaerobes, okay? Very important. So this is good. Alternative to these things, alternative to Vanc and Zosyn, you can give another big gun. You know what's the other big gun that can be given?
Maybe Meropenem.
Ooh, nice. Yes, Meropenem. So Meropenem will cover everything, gram positives, negatives, Pseudomonas, anaerobes. But do you know a situation where Meropenem is actually might not cover MRSA, you might still need Vanc. What do you think a situation where Meropenem is like indicated? So is there something?
If the patient was already hospitalized, I'm thinking of more resistant bacteria.
So what's the more resistant bacteria? Somebody says seizures. Okay, if somebody has a reaction to Zosyn or reaction to piperacillin, yeah. But there's an organism that piperacillin doesn't cover. So remember, piperacillin is what? It's an extended spectrum what? Penicillin, right?
Penicillin
is at the end of the day, it's a penicillin, right? What's tazobactam? Tazobactam is the one.
Beta-lactam.
It's a beta-lactamase like inhibitor.
Yeah.
So it inhibits the enzyme that kills piperacillin. So it's amazing, right? Except there's one bacteria, okay, or multiple group of bacteria. We call them ESBL. So these are extended spectrum beta-lactamase producing bacteria. So these things, they have resistance to tazobactam, these bacteria, okay? So if somebody has a history of ESBL, these can be E. coli, they can be Klebsiella, then you really want to use Meropenem. You don't want to use Zosyn, okay? So in your mind, these things have to be going on, despite the patient is currently hypotensive, but you really want to give them the right medication, because if you don't, you might, your antibiotic might not work. And remember, the time of sepsis until the time of antibiotic, this time frame is the most important time frame. It's the most related to patient survival, patient prognosis later on, okay? So really, time to antibiotic is like from sepsis to antibiotic. That's what everybody looks at. That's what all the research, that's what all like the clinical trials look at, okay? So it's really time to antibiotic, to the correct antibiotic, not just any antibiotic, okay? It's very important. How about IV fluids? What do you think? What kind of IV fluid are you going to give?
Normal saline.
Okay, so you can give, you can give normal saline, but I'll tell you what, when they did all the trials, in fact, even more recently, like there's a lot of trials, they're saying don't use NS. Instead, the rising champion now is LR, okay? This is very important. And a lot of people are saying when you compare NS versus LR, LR is better, has less AKI for people. They develop less kidney injury and they have better outcomes in sepsis compared to NS, okay? Because NS itself is actually not normal. It's abnormal. NS has 154 milliequivalent of sodium, 154 milliequivalent chloride. It is acidic. It has an acidity of around 6.9, and it induces a non-anion gap metabolic acidosis. And so it might worsen the acidosis in these patients. So you kind of want to avoid it. LR is more physiologic, has some potassium. It's 7.5 or 7.4, I forget, but it's much better. So you want to give LR, okay? And, you can give like 1 liter, 2 liters. Do you know, is there a magic number? How much you want to give? It's tough. I wouldn't imagine you know it, but in general, if somebody is actually in shock, so if shock, which means if the lactic acid is high or persistent hypotension, then the magic number is you want to give 30 ml per kilogram bolus. Bolus means you're going to give it, all at once. Okay. That's kind of the recommendation from the surviving sepsis guidelines, is that you need to give this much. Again, if you don't give this much and the patient is in sepsis, they will find you. They will like, why did you give 1 liter instead of, whatever, 3 liters, however the patient weighs, okay? So these 4 measures, very important, and people will chase you afterwards, okay? You do all these things, and I just want to add one more thing, or like few more things, is that because, you have sepsis, or not necessarily sepsis, because you have hypotension, right? You will have like kind of in your mind, you have a differential diagnosis of the shock. So when you have a differential diagnosis of a shock, what is this differential in your mind? Just like grossly, what do you think about? So 4 things you have to think about, honestly. The first thing is, septic. So septic shock, essentially, or like, in another word, distributive. Remember this from your physiology, distributive shock. I mean, septic is not the only one, right? You have other things, anaphylaxis, liver disease,
urogenic shock.
Yep. And then somebody mentioned it, hypovolemic, right? Because this patient might, might be bleeding, right? You don't know. Okay, so it could be hypovolemic, and then it could be what? Cardiogenic. Okay, and then finally obstructive. Anas just mentioned it. Yep, obstructive. Right? So obstructive, like what? Like PE, right? Or tamponade. And then cardiogenic, you have like an acute MI or like CHF, severe CHF. And then hypovolemic, the things that people think about is GI bleed. Okay, so these are the things. Which one of these do you think will get worse by the above measures? What do you think?
Cardiogenic.
Cardiogenic, yes. So be aware of this cardiogenic shock, okay? Because it might fool you. You might, the fluids, will worsen the cardiogenic shock. I'm just gonna, okay, so be careful of this. Usually, I mean, honestly, in the acute setting, like when you're like working the patient out and you don't see a lot of signs in front of you, sometimes the only thing you have in life is just the hypotension. The patient has no other history or something. So you have to improvise. And a lot of times you will make a clinical judgment, you will make a clinical call. And that's, shock and pressors and right heart cath is a talk for another day. But in general, you will have these in mind, okay? I'm talking about something acutely right now happening, okay? And so what I would usually do is, because you have these things in mind, okay, I would also order like an EKG, and I will also order troponins on these patients who have hypotension, just to make sure I'm not missing anything, okay? And the ABG will tell you, in the beginning, you already ordered an ABG that will tell you a little bit about if they're like desatting or something else is going on, okay? So after all these measures, so you did all these measures, and then, right, you can either have resolution, then, you're done and you started the management or whatever, or you can have no resolution. So after all you did, you gave the fluids and everything, and patient's blood pressure is still 90/40. Okay. Now, what are you going to do? What do you
Now
think?
we need vasopressors.
So now you start thinking about
ICU.
Exactly. So at this point, patient probably will need ICU transfer. So this can happen either by consults of the ICU, or if it's too fast and you really need to get them there, then you can call the rapid response team. It's called RRT. Okay. And this will initiate kind of a whole thing of ICU transfer. Okay. So you want to kind of page the fellow or the resident, whoever is covering the ICU at that point. Okay. Let's say you page the ICU. Okay. And then, you're kind of, waiting. And then now, while you're waiting, the blood pressure is 70/35. It's just getting worse. What can you do? Somebody said pressors, right? So that's a valid idea. Usually pressors are like kind of a no-no on the floor. You can't put somebody on pressors on the floor. They have to go to the ICU. The other thing you have to pay attention is that you can't give pressors through a peripheral line. All of these patients will have like a small 18 gauge, whatever, even smaller 20 gauge peripheral line. And you can't really give pressors through peripheral line, except one. Do you know which one? So
yes, epinephrine in anaphylactic shock.
Epinephrine and anaphylactic shock, you can give IM. You're right. But this guy, like in this setting, you're not really thinking about anaphylactic shock. You're thinking more about like septic shock. So usually in these settings, you want to start pressors even prior to ICU, because you can't wait. Because you can't wait. And the pressor of choice through peripheral, if you want to give peripherally, the pressor of choice usually is phenylephrine. Okay. Phenylephrine, by the way, if you come to the US and you say phenylephrine, no one will understand. No one will understand what you say, because they're so used to to trade names. They don't even know they might not even know. They should know it, but some people don't know it. And so you should know all the pressor names, the trade names. So phenylephrine is called Neo. You will hear them say Neo because it's called neosynephrine. That's just the trade name, and everybody calls it Neo, and no one calls it phenylephrine. Okay. So you can give peripheral, essentially peripheral Neo or peripheral phenylephrine. Okay. And this, you give it until the patient eventually goes to the ICU. All right. Let me ask you a question. If I give norepinephrine through a peripheral IV, what's going to happen? Like, what's the problem? Do you know?
Necrosis, probably skin necrosis.
So you're gonna risk causing essentially ischemia, limb ischemia. Okay. So you give neosynephrine. Hello. What's a little thing you should know about neosynephrine? When they studied it initially, by the way, when we started dealing with the shock, we used to put everybody on phenylephrine. That was the pressor of choice, especially septic shock, right? When you think about septic shock, it's distributive, and phenylephrine is what? It's like an alpha-1 agonist, doesn't have beta-1 and beta-2, so it like constricts all the blood vessels. It's perfect, right? You can think about it. It's like, yeah, you're counteracting the endotoxins. Physiologically, it's nice, it's perfect, but when they study it in randomized controlled trial, they found that neosynephrine or phenylephrine increases mortality in all shocks compared to others. Whether you use it for septic shock, whether you use it for cardiogenic shock, for any other shock, it increases mortality. That's why it is never the first choice, okay? It is only the choice when you're like stuck. You can't do anything. The patient is still hypotensive. I need to get the pressures up. So might as well use it temporarily, okay? Just think of this. That's why this is a temporary measure. Sounds good? Any questions about hypotension? Okay, awesome.
Is there just
Yeah.
one question?
Tell me.
Is there like a maximum number of IV boluses that you could give? when the patient-
You're going to give one. Essentially, here in this situation, when you're giving the IV bolus, this is just one bolus. Then it depends on your clinical judgment about whether or not you need to give more. So if you give once and you see there's no improvement, then right away you're thinking about more stuff to do. Okay, you want to continue broad antibiotics, do something. Okay, another question, by the way, is let's say a person is already in the hospital with pneumonia, okay, and you get paged 2 a.m. in the morning, patient is hypotensive. Same exact scenario, but the patient already is on antibiotics. So when you reach this step, in antibiotic step right here, the most important part is to widen the antibiotics. You can't say, oh, they're on ceftriaxone, it should be okay. Never. You have to broaden spectrum, okay? So very important. If they're on just ceftriaxone, you broaden. If they're on vancomycin, you slam them with meropenem, okay? If they're on meropenem, you start thinking of like fungals and weird stuff because, you're a max, okay? So that's a problem, is that if somebody is having sepsis despite all these things, sometimes you reach a point where like extreme drug resistant organism, you can't really treat.